So we're going to move into depression. So depression, so RNAO best practice guidelines speak to nurses need to maintain a high index for suspicion of depression, right? So early recognition and treatment, we are so successful, right? So in order to facilitate support, individualized care, right? So we can really actually have a lot of success treating depression in long-term care. Right? So what is depression? It's multifaceted syndrome, right? It's comprised of a constellation of affective, cognitive, somatic, and physiological manifestations. It's treatable, right? We can treat depression in long-term care. We can treat it in the community, okay? It's the most common mental health disorder that affects our residents, okay? Prevalence in the community, 1 to 20% of residents have depression. In acute care, it's 15 to 50. In long-term care, it's 12 to 45%, and I think this is probably higher now that we're actually able to detect it, and we have better treatments for it now. Risk factors. There's a lot, eh? You don't want to be on the right side. So female, widow or divorced, history of depression. So, you know, interestingly enough, they say female, but I think we're doing, it's tough to assess depression in males, right? Strong. We have a high community of veterans.
That's right.
Right? Veterans aren't going to let that guard down. They've taught to not let that, exactly, Joyce, they're a man, they're tough, right? If you're depressed, then you're no longer suitable for service, right? But we're doing a really great job with our team identifying, and we have a lot of residents actually now that we treat with depression that are male, that are veterans. Right? So widowed or divorced, history of depression. So if you have a long-standing history of depression, there's a resident that we're seeing, he's had 2 admissions to the Royal Hospital for treatment of severe depression. Guess what he needs to be on right now?
An antidepressant?
Yeah. I know, I looked at his file and I thought, well, you know, he's had 2 severe episodes of depression. We need to look at that, right? Personality type, social factors, primary caregivers. Primary caregivers have a hard time with this depression, right? Taking certain medications, excessive alcohol. I always thought that that was an intervention, but clearly not. Major physical and chronic disabling diseases, right? So medical illnesses, right? So CVAs, Parkinson's, dementia. 3, you know, recent major physical illnesses in the last few months. Cancer, right? We have somebody who's got a diagnosis of cancer, right? CHF, MI, COPD, endocrine, right? Medications, beta blockers, DIG, analgesics, steroids, Parkinson's medications, benzodiazepines, right? Antipsychotics. So RNAO best practice supports the use of the geriatric depression rating scale, Cornell scale for depression, and SIGI-CAPS. That's in your package, okay? As practice, so I know our RNAO best practice guidelines speak to it. I find SIGI-CAPS is the easiest for us to use. Some physicians like the geriatric depression rating scale because they like a number. I like the depression rating scale from the RIMDS. If the information is accurate, we get a good number, right? So assessments, right? So the resident may actually be able to report, but does my resident have to be crying do they have to be, I'm blue, I'm sad, I'm weepy to be depressed? No, right? So we'll do a workup on them, right? We'll use an interdisciplinary approach to do our assessments, right? Sometimes we'll get the Royal to help us with this, for sure, right? So that's your geriatric depression scale, okay? Your scoring. Right, so I'm not going to go through it. We could probably do a whole day on just assessments and what we do and how we use the tools. So I just want to give you a look at it because I don't think anybody ever actually sees the tools. So I want you guys to see what some of the tools are that we use, right? So SIGI-CAPS, so S is sleep. I is that interest ability to obtain pleasure is decreased. Guilt feelings or feelings of worthlessness. Energy is lower than usual. Concentration's poor. Appetite poor. Weight loss. P is the psychomotor changes, so any anxiety that they may be having, and S, of course, is suicidal ideation, right? Some of the challenges that we have, of course, are our residents with dementia aren't going to tend to verbalize that they're feeling this way, but we'll see behaviors, right? So absence of, They may actually just, you know what, I got some bad nerves, right? They might just tell you that they just kind of feeling blue, right? Sometimes they're crying, but some residents just don't experience the emotions, right? That emotional change is gone. We know that with our 8 A's, right? That ability, the memory to be emotional is gone. It's broken, right? We'll see poor sleep. And important again to differentiate between apathy and depression. Anybody remember some like what would be the difference with them?
Between what?
Apathy and depression?
Apathy, or their get up and go. Depression, they don't want to do anything, period.
Exactly. So what are some non-pharm and pharmacological interventions that you could use for somebody with depression?
Keep them listening to them.
Keep them active. Sorry.
Keep them active, listen, validate, take some time, right?
Arts and crafts, that sort of
Retrospect
thing.
on what they like and what made them happy.
Excellent, excellent. So find out what makes them happy and put that into place, right, if you can, right? Use an interdisciplinary approach, right? Make sure the residents involved, the family member involved, and staff. The more timely we are with our interventions, the more successful we are with the resident, because we know we can treat it, right? So some of the non-pharms, so that cognitive behavioral therapy, counseling, I heard somebody say listening, right? Stress management, exercise, going to activities, diet, sleep patterns, what can we do to improve their sleep? Reducing drugs and alcohol. We have great, you have the Snoozaloon cart within here, right? So you could do aromatherapy, music and art therapy, right? Recreation therapy. The resident on Morito 1 South has a light therapy in his room. I'd like to tell you his room number, but I can't. He's got the abdominal pain. French, goes to Ottawa Building to see his wife.
Oh.
Right? Yeah. ECT is very successful to treat depression. And some staff fear it because we've maybe watched too many movies. It is very, very successful.
Always has been.
Yeah, always has been, exactly, Lorraine. It always, always has been. We've had a lot of successes. Yeah, absolutely. It's been a long.
Can I just add something to that? Socialization.
Mhm.
I have a resident on Ottawa 1 West who stayed in her room when she first came in. We were trying to encourage her to join activities and do things. She said, no, I've never been social. I don't want to do anything. Just leave me alone. I'm not even coming to the dining room for meals. Well, she came to the dining room once or twice, and she became friendly with one of the other residents, and now she goes to activities.
Isn't that great? So pharmacological therapy, so we talked about the number one rule is low and slow, right? So the type of treatment is the severity of the depressive disorder that we're dealing with, okay? We don't start antidepressants without a comprehensive health assessment, your nursing assessment, which we talked about, which is so valuable, right? Monitoring any sodium levels. We used to do the ECGs with Celexa and Cipralex. I'm not sure if we do them quite as often. And then if we're using benzodiazepines for depression, it really better be temporary. That's just kind of a momentary thing, and we need to be actually treating depression with antidepressants and other non-pharmacological therapies. That non-pharm approach to treating depression is equally as important as the treatment with medications, okay? Suicide, very seriously. Any expression of suicide must be taken seriously. There must be immediate interventions and called to the pharmacy, called to the physician. Communication with the families. They need to be put on close monitoring, so acute 15-minute check, right? Referral to the ROH if need be. I tend to get the ROH involved with right away. This is your referral to the geriatric outreach team. So this is in your binders on the unit. Okay, who processes this? Who processes this form? Who fills this out?
You?
MD. No. we
Nope.
The physician?
Nope.
No, the unit staff.
Yeah, RN on the
Registered
unit.
RPN.
Yeah, RN or RPN can fill out this form. Nope. You know what though? I'm glad you said it because it used to be this role. This role used to go to the unit, fill out this form and fax it for you. That is not required. Okay, you can fill out this form. The RN, the RPN can fill out this form, but what do I need before I send this form?
Consent from the
For the
family.
physician.
Excellent, physician's order. Then I need consent. And on that consent, I need to complete the consent 100%. So the person who's consenting, right? At the bottom in the right-hand corner, you have the family member, whoever has to sign It has to be witnessed by a registered staff, right? They can't proceed unless they have a signed consent. So date, witnessed, names. They also can't proceed until this is completed. So they need room number, they need the date of admission to the long-term care home, they need their last name, a maiden name, right? Surname, former surname, right? The date of birth, they need this filled out, okay? But they need this information filled out completely, 100% before it's faxed, because they'll send it back to us if it's not, and that just delays it. And go ahead and fax it, or have your unit clerk fax it, but you need to complete it and you need to fax it, okay? With a doctor's order. Documentation is the key. We learn that as nurses, right? Document, document, document. I've got documentation and point-click care. So dementia, delirium, depression are not synonymous with aging, but prevalence increases with chronological age. So if we do our job and we work together as a team and we meet those unmet needs, this is what we look like. This is our goal, right?